Because we believe that for patients who are going through the IVF treatment in our center, if they have an understanding of what the process is, it will help them to be part of it and to get the best. All right, so that is the purpose of this interactive session. Because the promise of excellence and quality fertility care at JOJE is a commitment we owe all our clients. All right. And to ensure that we're able to provide this quality care and serve our patients well, our patients must be empowered with the knowledge of IVF. I'm aware that there are some of us who probably have done IVF before in other centers and probably have had experiences as to what to expect. And there are some people who have not done at all, and this is their first time. Next slide, please. And this is their first experience. But whatever it is, whatever background that you have, it is important for you to have some basic knowledge of what this process is all about. It helps us, all right? It helps us. It helps you to ask the right questions. It helps you to follow instructions. And it helps you to ensure that we have the best outcome. For example, during the process of this IVF, there is an injection that you're supposed to take, the Zolades injection, for those who are doing the recipient program. And if that process does not get completed within 28 days, you're supposed to continue with another medication, injection called buserelin. Now, a patient started that buserelin, took the first shot and refused to come. Unfortunately for us, our people didn't follow up. They didn't know that she wasn't coming. And she had done this program before, and she took buserelin, but for some reason, she just thought that I've taken one, that's all. And then she didn't come. And so because of that, the program had to be canceled and start all over again. There are some patients who will take extra fat medication, and once the one they've been given is finished, they just stop. Why did you stop? Nobody asked me to continue. Oh my God. Probably after you're 3 months pregnant, because it's something you must continue. It's what supports your endometrial lining. Oh, they didn't tell me. They just gave me, I just felt. What did you... So I should stop. Or the patient who was given Levofem to take to regulate her menstrual cycle, and she's not based in Nigeria, and she was sent her medications abroad. She was given enough just in case we needed to increase the number of days. And she was sent a plan. And we were waiting for her. You've not seen your period, because you need to see your period, you need to start medications, you need to book your flight. And she says, I've not seen my period. Have you stopped Levofem? No. Why? It has not exhausted. What? Did you go through your plan? Well, did you see the number where you're supposed to have stopped? Well, you should have gone through your plan. You see? So it takes the two of us to have a successful outcome. And that is why what we have decided to do is to take us through the whole process of IVF. All right, as it is at the JFC, the Abebe Fertility Center. So that at every given point in time, you know what to expect, you know what to do. So if it's not happening that way, you say, come wait. MD said this. Why is this? Please explain to me why. So that you can question and you can challenge the system. That is why we are doing what we are doing. All right? So the plan is to concisely lay out the IVF process that clients will go through. Okay, next slide. So I'm sure that for every one of you seated there, you probably have gone through this first phase at the beginning. At the beginning means that you have gone through registration, you've had your consultations, and some of you have had multiple consultations by now. All right. And So, well, no, yeah, we are fully. So even when NEPA goes off, we don't go off. Yeah. So, so you have your consultations. Then after you've had that first consultation, you have a fertility. You have your tests, your investigations done. I want to believe all of you have had your investigations. You don't just come and start off a process without having investigations. It's very important for you to go through investigation, both you and your spouse. All right. And after you've had the investigations, you will have a result review. You must sit down with a specialist to have the result reviewed, to tell you this is what the result is, and this is the implication. And based on the results, we will then tell you what the treatment option would be. And so I want to believe that we've also gone through that process too, of going through the investigations and then discussion of the treatment options. Next slide. And once we have decided what treatment option we are going to take you through, and you've made the necessary, you have fulfilled the terms and conditions, meaning that you have made your payments, then you must have a treatment plan. How many of you have gotten a treatment plan? Or how many of you have not gotten a treatment plan? A treatment plan is a sheet of paper that have dates, tentative dates. This is when you are supposed to take this medication. This is when it will end. This is when you're supposed to take this injection. This is when you're supposed to see your period, all of those things. This is when you're supposed to have your insemination or egg collection, and when your transfer will be. Although those dates are tentative, but it's a plan. All right. And it helps to guide us through the process. So it's a summary of your treatment process with the date. So what will happen is that every one of you is given this sent a plan, and the team calls to explain the plan to you, or you come into the hospital physically when that is possible. The plan is explained to you. You have an understanding. Now, if this patient had an understanding of the plan, she would have known that the level firm she was given, although she had more than enough, she was not meant to exhaust all. She was supposed to take it, start it at a particular date and end it at a particular date. All right? Just a minute, Dan, tell them to put on the gen. We are on the inverter, so somebody is already feeling uncomfortable, and shouldn't. Sorry about that. All right, so for patients who are in Abuja, we encourage them to come into the hospital so that they can have the treatment plan discussed to them physically. And if that is not possible for those who are outside Abuja, they will have a call. They would have sent you the plan with a voice note explaining everything, and then they also will call to ensure that it is well understood. And then after that, you'd have the consent form signed. How many of you have signed a consent form? Show of hands. Very good. Good. So that means you have gone through the process as it should be. So you have a consent form signed, and the consent that is given depends on what program you are doing. All right. And then once you have signed the consent, and then the program would then be executed. For most patients, next slide. For most patients, next slide. For most patients, they will go through what we call a menstrual regulation. Menstrual regulation means that we will give you medications to help regulate your menstrual flow, all right, so that it would, you will see your period when you're supposed to see your period based on our terms, all right? And whether it's a recipient program you're doing or it's a self program you're doing, most patients would go through a menstrual regulation. So either you are using the level firm or you're using Primrose N. Whichever one we decide to use, it depends on your own profile. So when you have a friend who you're together on the program and they give the person level 5, say, this doctor, this people, they made a mistake. They gave my friend level 5, they gave me promote N. Why? What is the matter? No mistake was made. And that's why we often would tell our patients, don't compare yourselves. It's not everything that your friend does that you will do, because your programs are different. All right? But the whole essence of the menstrual regulation is to help you to see your period when you should say it. Okay? And so you start off the menstrual regulation, it has the starting date and it has an ending date based on the plan. However, sometimes we may decide to call you and ask you to extend the number of days of menstrual regulation. That is because of our own internal workings. Once we feel that it's important for you to extend it, the nurse will give you a call and say, please, you're supposed to stop on this date, but don't stop. Continue. Because we're also trying to ensure that things are also working. And once we feel that if you stop at this time, we will not be ready for you when you see your period, we will ask you to extend it. It's all working for your good. All right. So these pills, there are patients who will take these pills. Most of these pills don't have very terrible side effects. All right, but I just to make you know that, just to let you know that some of you will probably have some little side effects because they are hormonals. All right, and if you've used these pills before, much younger, to prevent pregnancy, then it's those side effects that you usually would have, but they are not that harmful. All right. So you're welcome. Welcome. All right. So typically for patients who we want them to use Levofem are patients who, for those who are using their eggs, we want to use the agonist protocol. As I said, it depends on what protocol you are using. If we are using the agonist protocol, we would prefer that you use the Levofem. It helps to provide some form of down regulation. If you're using the antagonist protocol, we will prefer you not to use anything at all, or you use Primolute N. All right. Now, there's some patients who may not use any of this. We want them to use the natural cycle. It depends on the protocol that we are using. And again, for patients who are recipients, who are doing the egg donation program, we may decide to use Levofem or use Primolute N, depending on when we're seeing them. For example, a patient who already has seen her period and we are seeing her 2 weeks after she has seen her period, and we want her to join the program immediately in using our nurse circle, we will use Primolute N. Why? Because we can't start Levofem because it's already too late. Levofem is usually started at the beginning of a woman's menstrual cycle. So you can see why we use the different medications. All right. So that is done. The other thing that is important that you will go through is what we call down regulation. What does down regulation do? It helps us to take over your body system, because we don't want your body to produce hormones that will alter what we are doing. And so virtually all patients will go through down regulation. The only patients that don't go through down regulation are those who have already lost that control. And these are women who are already advanced in age, who have stopped menstruating, all right? Or those who, yes, they've stopped menstruating, whether it was normal menopause or whether it was premature ovarian failure, or, you're welcome, sir, or primary ovarian insufficiency. All right, for those set of patients, they already have lost, their ovaries are no longer functioning, so they will not need to take the injection to downregulate. So again, don't compare. You see a patient, say, I took injection in my tummy. Did they give me an injection? These people, they have done it. They have done it. Did they give you injection? Say, why? It's not a mistake. It is based on your program. You were not given that injection because you didn't need it. What you don't need, you won't be given. Exactly. Because that injection is not meat pie. So you take it because you have to take it. So if you don't need it, you won't get it. All right. And so when we give that injection, also depends. All right. For women who are going through the recipient program, the egg donation program, they usually will take it day 21 of their last menstrual cycle, or on the day they are stopping the menstrual regulation. All right, you take that injection, and for those particular set of patients, they are giving that injection, and it will last for 28 days. Usually within 28 days, before that injection expires, you ought to have gotten to the point where you have started another injection called progesterone. If you have not started, if you've not gotten to that point where you are now asked to come and start gestone, that's progesterone, that means we have already done the insemination. Fertilization has taken place. We've had the egg retrieved and then inseminated with your spouse's sperm. And then the next day you are starting gestone. If you have not gotten to that point and you are still taking the extra fat to prepare your womb, you will be asked to come and continue with the daily injection of this down-regulating agent, which is buserelin. All right? Why? Because if you don't continue with the buserelin, we will lose the control, because this Zoladex will only last for 28 days. All right? But most times, patients would have started gestone, so there'll be no need for you to take the extra injection. Now, that was the injection I said a patient started, took the first one, and she didn't continue. All right? Now, some patients may not be given this depot injection that will last for 28 days.
So I know you referring back to that topic. So the gestone, is it going to be, you tell us how long to take it, or is it fine?
Yes, you keep on taking it until we tell you this is when, when to stop. All right. Now, for self patients who are using their eggs, this down regulation can occur. There are different protocols. There are some who will take it on the 21 of the previous cycle. That's what we call the long protocol. There are those who will start it on the day they see their period, or the second day. Same day, they're also starting the injection to stimulate their ovaries. That is the short protocol. Now, there are those who would, if you are using the antagonist protocol, who will start it day 6 or day 7 of stimulation. So again, it depends on what program you are running. Next slide. All right, so once you've taken that injection, you started the down regulation, then you're expected to see your period. If it's the long protocol or if you're a recipient program, you are doing an egg donation program. Now, once you see your period, you are expected to book an appointment to come to the hospital. And what are you coming to do in the hospital? You have a scan done to check your ovaries, check your womb. No, before that, check your ovaries and check your womb. And then you're either commencing the stimulation if you are doing stimulation of your ovaries, if you are using your eggs, or you will start endometrial regeneration if you are using an egg donor. All right? Now, during that consultation, you will have what we call a mock embryo transfer done. How many of you have done a mock embryo transfer? If you have not done it, that means you have not reached that stage. All right? The beginning of the process, this is the main process. You have seen your period. Day 2, book an appointment. All right? Book an appointment on day 2. Again, there was the patient who she was given the plan. She went through the plan. And according to the plan, once you see your period, what are you supposed to do? Your period. What are you supposed to do? Book an appointment. Yes. You call the nurses, but better still, just book an appointment on day 2. Because on that day 2, you're coming in to do your mock and then to start your program, either stimulation of your ovaries with injections or your endometrial regeneration. This patient did not do any of them. He didn't book appointments. She saw her period and just relaxed. Until her Zoladex expired. And then, of course, we knew when we gave her Zoladex, so the nurses are documented this woman is to be called on so and so date to come and start viscerally. And we called her, and she came, and then we now realized that this woman has not been coming for scan. What happened? Nobody told me. I didn't know. But you had a plan, yes. You went through the plan, yes. So you can see why we are emphasizing this, that you need to know the process. Now for that patient, the program was canceled. She had to start afresh again. Because you can't, she didn't come for that scan. She didn't start any medication. Her womb was not ready, was not built up because she didn't come. You have to come for that scan, have your mock done. Or if you have done a mock before, maybe this is not your first cycle you are doing, you come in and then you start off your medications. And then you come in for your regular scans. We will get to that. Okay? So this day 2 or day 3 consultation appointment is very, very important. And it is an appointment that you must come for, having had a prior appointment. So you call the front desk and book an appointment. So for those who are, next slide, for those who are going to be going through stimulation, they would start off the stimulation process. Next slide. You'll be giving, we will do a scan to ensure that your ovaries are okay. Now, if there is a cyst in the ovary, we can't start off the stimulation. We have to drain that cyst before we start off the stimulation. Or we will give you medications to take, and that means we have to move your program to the next month. All right? And if we have to drain the cyst, terms and conditions will have to apply. That will be an additional cost. Okay? But everything is fine with your ovaries. You'll be given medications. Now, for all patients who are going through our programs here at GFC, they are given routine antibiotics. Both spouses, the man and the woman, are given antibiotics. We're not saying you have infection, just in case. So the man will take antibiotics and the woman will take antibiotics. And then there are other medications that are given, like folic acid, aspirin, and vitamin E. Vitamin E is an antioxidant. It helps the body system. Aspirin helps to thin your blood, makes perfusion better. And Of course, folic acid is good for cell growth. All right. Now, if you're going through stimulation, you take injections. You'll be on daily injections to stimulate your ovaries. If you're on endometrial regeneration, you will take tablets. Injection tablets, which do you prefer? Tablets? Those who say tablets, say hi. Everybody's tablet. So people don't like injection.
This medication, I know it's very antibiotics. I did take it. They gave it to me at the beginning. But it's good for them to ask you what your allergies are, because I have allergies. I'm allergic to moxie.
Yes, definitely. So when you get to the pharmacy, when they're explaining to you the medications you're taking and they give to you, they'll tell you what the side effects are, if there are any. And then, so a lot of patients already know they have allergies because you have your history. Okay, so that is why we're having this. You must be involved in your care. So it is your right to know what medications you are being given. It's your right. So you go to the pharmacy and they say take this. You ask this, what is this? We're not those people that they will take the pack out of this thing and just write it and say take this. No. You must know what you are being given. And if you have allergy to that particular medication, we will look for a substitute for you. Okay? Okay, so next slide. So for patients who are coming in who are going to be going through stimulation, we would have determined what your starting dose is. But this is already determined pretty much at the beginning. For patients who are coming through the foundation, the cost is dependent on what you are doing. Okay? And so if we already determined based on your age, on your BMI, and on your results that you're starting with a particular dose, then that is what you are paying for. And then you'll be told that if we need to increase the dose, you'll make the additional payments. All right? And so our normal standard dose is 150 to 225. That is 225. Maximum dose is 300. We don't go beyond 300. Okay? And then you're started on that dose. And if there's need to increase the dose, then we would increase the dose. Now, once we start the stimulation, you start coming for scans regularly. After the first day 2 scan, the next scan you're coming for is after 4 days, which is a day 5 scan or day 6. Day 5 of stimulation, day 6 of circle. And then we're checking your ovaries. We're measuring the number of follicles you have and the size. That is how we determine whether you are making progress or not. The size of the follicles. We expect that by day 5, when you come, we would have seen an increase in the size of the follicles. By day 7, after day 5, we start measuring every other day. So you come on day 7, day 9, day 11. And each time you come, we'll measure the size of the follicle. And we expect at those days, we know what we expect the follicle to be. On the 7th, for example, we expect for you to have minimum of 12 mm in the average size of the follicle. This. By the 9, it should be what? 16. By the 11, it should be what? 18. So if you come on the 7th, for example, so let's say the 5, which is the next time you're coming after you started your injections. We'll look at it and just say, okay, she's responding. Okay, so let's continue. Or, oh, she's not responding well. Let's step up the dose. Maybe you started with 150. So, okay, let's step it up to 225 or 300. Or, oh, she's doing well. No need to increase the dose. Continue. By the 7 of stimulation, you would come, we measure. Okay, the average diameter is 14. Oh, fantastic. She's doing very well, because that's what we expect. Oh, it is 12. Not bad. 8. She's not doing well. 8 mm. It's not doing well. Okay. Then at that time, we now start deciding what to do. We look at the 5. If we have not increased the dose, okay, step up the dose. And then we'll step up the dose, and then we'll scan you on day 9. Day 9, we measure, and you have done, it has increased. From 8 mm, you're not getting like something like 11 mm. Okay, that's very good. So let's continue with that. Or we do a scan and no change, still the same. This patient is not responding to this medication. And maybe at that time, we have already stepped up to 300, which is the maximum. At 300 IU on day 9, when we're supposed to be having 16 mm average, we have a patient that is having 8, 9. And we'll tell ourselves that this patient is not responding, and then we need to stop stimulation and then counsel on the other options. But most patients will respond. Some patients may need to have a dose increased, and then thereafter they will respond. We typically would stimulate for 12 days. So women will be on that injection for 12 days. Long, right? Yeah. But the needle is small. Not that painful. Yeah, I know. Me, I know. If it was men that was taking this injection, I know men would not agree. Women, they are stronger. Yeah. Okay, so you're giving injection on your tummy, okay, below your belly button. That's when you take the injection, a sub-Q for 12 days. When do we stop giving you this injection? I just said that average number of days you take it for is 12 days. That is what we do for all patients, no matter the goal of this stimulation. We want to ensure that we get eggs that are matured. If a woman produces 10 eggs and all the eggs are immature, it's equal to 0. You can't do anything with those eggs. So it's not just getting eggs, but getting matured eggs. And what we use to determine maturity is the size of the follicle. That's what we use to determine if the eggs are maturing. It's 3 follicles that measures at least 17 mm. We know that we are getting there. Now, this is what the textbook says. But what we do practically is that we don't use only 3. We try to make sure all the follicles they have got into the 17. Because I don't want to retrieve 10 eggs and only 3 are matured. It's only 3 eggs that we can use and not useful. So we aim to have more matured eggs. And so some patients may need to now do 13 days, some 14 days, some 15 days, some 16 days. 16 days. All we're trying to do is to ensure that we get as many of the eggs to maturity. Next slide. So once we have gotten to that point where we believe that most of the eggs are matured, you will now be given an injection, your last injection. In fact, your last 2 injections are timed. The last injection that you are giving that stimulates the ovary. And by the way, you will notice that we use 2 different kinds of injections. The first one, which is highly purified FSH, and the second one is a combination of FSH and LH, the HMG. That's what we typically use as our protocol. All right. The last HMG you will take is timed, which will be 24 hours before you take your trigger injection. So once we already have determined that, okay, we have gotten the right size, you'll be giving your last HMG, and 24 hours after you take your last trigger injection. That trigger injection determines when your OCR will take place, because it should be 36 hours after. Let's say, for example, you take your trigger injection by 7:30 p.m. tonight. It means that your collection will be when? 7:30 a.m. on Monday morning. If you take it by 8 o'clock tonight, it means 8 a.m. will be your retriever. 36 hours after you take your last injection. And when you take that last injection, on that day, you must do a test we call progesterone test. It is very important for you to do that because it helps us to determine whether you go ahead with a fresh transfer or if we should freeze your embryos. Because if the progesterone level is high beyond a certain level, it means that that endometrium, we may miss the window of implantation. And so if we go ahead and do a fresh transfer, it will reduce your chance of conception. So when you come in the day of your trigger injection, for those who are going to be stimulated, in case we forget to say, you need to do a test on that day. This only applies to patients who have been stimulated. It doesn't apply to recipient patients. Okay? Yeah.
So I'm thinking about the difference between the fresh and the frozen. So the only reason is
yes, so the progesterone. And then also, we will get to that. There are some patients whose progesterone level is not only high, but they also have developed what we call ovarian hyperstimulation. For patients who have developed ovarian hyperstimulation, we would elect to freeze their embryos, and then they will come back later to have a frozen embryo transfer. All right? So I said before that part of what is done is that you commence antibiotics and then other medications. Next slide. So I'll talk about the dose, and then that we use 2 different medications. You start with one and then you change to the next one. Your stimulation starts on day 2 or day 3. Day 2 or day 3, not day 4. So if you see your period and you're not in Abuja and you don't have your medications, you must plan to be at the center either day 2 or latest day 3 to start off your stimulation. Next slide. So that's a transvaginal scan of the growing follicle. That is what you see when you are being scanned. So you see they're scanning you and then you're seeing those black, what you're seeing there are just follicles. And so what the doctor would do, or the nurse, it will count the number of follicles, because we need to also know what number of eggs we are expecting on that day. And then they will measure the size, the biggest size, just few of them, and then also measure your endometrial thickness. Because it's also important that as your follicles are growing, it should also reflect on your endometrium. Next slide. Okay, so I think I've mentioned this 12 days of stimulation, and then you're giving your trigger. Now, you start off with 2 medications. For those, if you are going through the short protocol, you start off with 2 injections, the buserelin and then the stimulating agent, the folliculin. Not 1, 2, if it's the short agonist protocol. If it's the antagonist protocol you are on, you start with 1 first, the stimulating agent. The antagonist is added later on day 6 or day 7. And like I said, for the stimulating agent, you start with 1 and then you change to another one. So when you see a different injection being given to you, ask questions. But this is not what I was using before. The nurse will explain to you that, yes, you have had this for this number of days. It's time for you to now change to the next injection. The difference between the 2 of them is just that one of them contains just FSH. The second one contains LH in addition to the FSH. And for you to have good results, you must have a bit of the LH, which will come up later in the protocol. Okay. Now, for those who are recipient patients, when we say recipient, we mean that those who are on egg donation program, your process is a bit easier because you don't go on those daily injections. Instead of taking the injections, you take just one injection to down-regulate, which is the Zoladex, that lasts for 28 days. After you see your period, you start with endometrial regeneration with the extra fat estrogen. The follicles are supposed to produce estrogen when they are stimulated, and it prepares your womb. Now we are not stimulating your follicles, but we still need to get your womb prepared. So to do that, the hormone that is produced by the follicle is what we now give to you to make sure that your womb is prepared. All right? Because we can't just put the baby into a womb that is not prepared. So the womb is prepared. Next slide. And this is what we measure, the endometrial thickness. So for those who are on the recipient program, you come in, your visit to the hospital is less frequent. You come in every week. Unlike those who are on stimulation, you come in after day 2, you come after 5 days. After 5 days, you come every other day. So don't say, my friend, you're going to hospital. Did they ask me to come? Are you sure we are doing the same? You are correct. You're not doing the same program. So don't compare. Oh, they asked me to come after 1 week. No, women, they can discuss. You think they have not, they only met 1 day in the clinic, and after that, they keep calling themselves, okay, I'm going to the hospital. But they asked me to come. They asked me to come after 1 week. But me, they told us I should come the next day, 2 days after. You are doing different programs. Okay? I'm saying this to say that nothing is wrong. Just know the program that you're doing. So for patients who are going through the recipient program, you come to the clinic every week. So after the first scan, when you start off your medications, the next time you're coming, it will be after 1 week. And what are you coming for to do? Just to check your endometrial lining, to see if the endometrium is getting thick. What is the target? 7 mm. Once we're able to achieve 7 mm and above, we are good to go. Okay? And so you come every week until we achieve that. Now, we also want to make sure that, apart from the fact that the endometrium is getting thick, that there are no fluids. Because if there's fluid inside your womb, that already is not a good sign. We can drain it, but we don't like it. It's better there was no fluid at all, because it actually does affect the outcome. Okay? Now, if we do your first scan and we think that your womb is not getting thick enough, we may increase the dose of medication you're taking. And what of all the medications you'll be given, the particular medication that increases your endometrial thickness is the estrogen, the extra fat. All the other medications, folic acid, aspirin, vitamin A, those are all supplements. The antibiotics, yes, you take to ensure there's no infection. But what actually increases your endometrial thickness is the extra fat. And you're supposed to continue with that continuously. Just continue with it. Like I said, until you get to 3 months of pregnancy, you don't stop. Or when you don't get pregnant, we say stop all medications. As long as we've not said stop the medication, you continue with it. So if the one that I've been giving to you is exhausted, before it gets exhausted, come to the hospital and pick more. You'll come to understand why, for some patients, that length of time from endometrial regeneration may be more than what was even planned for you, what was scheduled on your plan. Like I said, there are a lot of other factors that determine how long you are on that medication for, but you don't stop it. So your antibiotics will finish. Yes, it finishes. You take it for 5-7 days and it's finished. That you stop. All right. But the medications that you don't stop is the extra fat, You also folic acid and aspirin. The vitamin E will finish, no problem. Okay? Even if the folic acid finishes and you don't continue, there's no problem. Or the aspirin. But if the extra fat finishes and you don't continue, there's a problem. Because suddenly you just realize that you call and say, come, I'm seeing blood, I'm spotting. Why are you spotting? What medication are you taking? All the medications have finished. Not finished. What about the extra fat? It finished 5 days ago. What? I say, okay, no wonder. No, we don't give 3 months supply because you're not expected to take it for that long. So we give normally for about 3 weeks. But like I said, some patients, their program may extend beyond 3 weeks. But once that medication is finishing, you get more. When you have your transfer, you still continue with it. When you get pregnant, you still continue with it until 3 months. And then you tail off. Then you can say bye-bye to extra fats. Okay? Okay, so for those who have gone through stimulation, it's time for the egg retriever. The egg retriever is not a painful procedure. For those who go through the oocyte retriever, it's not a painful procedure. Why? Because it is done under anesthesia. We don't do light sedation. Because with light sedation, you still feel pain. So I'll be telling you, sorry, bear it. We don't say bear. Don't bear nothing. We do general anesthesia so that you don't feel the pain at all. Okay? And the duration for the egg retriever depends on the number of follicles you have. Usually 10-15 minutes we are done with the collection. Some patients may extend more because of the number of eggs that they have. This is particularly for patients who are polycystic. And so after the retriever, you may feel some soreness down there, you may have some bloatedness. For patients who will develop ovarian hyperstimulation, your tummy really will become big. Fluid will accumulate. You will feel lots of pain. Not to worry, we will take care of you. All right? And then after you are done with the egg retriever, you will start gestone, another injection. Now this injection, according to those who have taken it, they said the pain is different. You don't feel the pain when it is given to you. It's after. You now start feeling one funny pain there. But most women cope with it. And that gestone injection you take for 6 days, up until the day of your transfer. Now, if your egg is collected from you and they don't give you that injection, ask, am I not starting my gestone injection? Because if you don't start your gestone injection, it means there's no transfer for you. Because it is that injection that will bring about the final preparation of your womb to receive the embryos. All right? So you're giving that injection and then some other analgesics just for pain, okay? And then you go home. And you take that injection daily. I said for 6 days. Every day you come to the clinic and then you take it. Our embryo transfer, for those patients who are recipients, you don't start your gestone on the day of the insemination. You remember, for recipient patients, we're not collecting eggs from you. We already have eggs. Your husband will come and then collect sperm and we inseminate, and then you start your injections. For recipient patients, your gestone is started the day after, not on that day. The question is why? Why would serve patients who you collect their eggs, you start their gestone on that day? And for me, and I'm getting eggs from someone, I'm starting mine the next day. The reason is because we want to be sure that the process is ongoing. What we mean by that is we want to be sure that there's fertilization. So when we get eggs and we get sperm from your husband, we inseminate. 18 hours after, we should check and see if there's fertilization. If there's fertilization, we can ask the patient to start gestone. If there is no fertilization, that means we can continue with that process. We won't ask you to stop gestone. We can still rescue that program. It only means that if we have a donor that is being scheduled, that fits, that matches you, in a couple of days, we can still repeat that program for you without having to start off the whole program again. All that will be required is that you just continue with your extra fed. So you can see why some people may take extra fed for a bit longer than others because of all of this. Once you can take extra fed for 35 days, for 40 days, as long as that, and you can take it for as short as 14 days, as long as you are down-regulated. That's why some patients, after 28 days, they may need to start taking buserelin to maintain the down-regulation. Like I said before, if you have not started gestone, you must ensure that you're down-regulated. After 28 days, you must start buserelin. Okay? And so you start off your gestone a day after. 5 days, 6 days is fine. So Seth will say, so me, I take for 6 days, she takes for 5 days. Okay, no problem. It's not intentional. It's just that we're trying to, because we were doing that before where recipient patients will start on the day of insemination, only for us to realize that the next day there was no fertilization. And once you've started gestone, you have committed yourself. You can take extra fed for us for a long time. There's no problem. But once you start gestone, you are done. Your body is saying, after 6 days, something must enter this place. If not, I'm breaking forth. All right? And so that's why we want to be sure of when we give.
Because there has to be something that makes you want to add this.
Yes, definitely.
So does it have?
No, it doesn't have. But we don't add an extra day, actually. Instead of taking it for 6 days, you're taking it for 5 days. Because you're not starting on the day of the insemination. You're starting a day after. It's still fine. Okay? We just want to make sure that we've achieved fertilization. All right? Next slide. No, the one before this. Okay, so for us here, we do our transfer 5 days after egg retrieval or insemination. Not 2 days, not 3 days. Setters you can actually do your transfer after 3 days, but we do ours after 5 days. Very rarely we do after 3 days. And the reason why we do our transfer after 5 days is because we want to be able to select the best embryo. Because day 3 transfer is the eggs are still cleaving, they're still dividing. That is the 8 cells. By day 5, they form what we call the blast. Those that are doing well on day 3, but when you check them on day 5, they've not done well again. Something happened. And so if you have 7 or 8 embryos that are cleaving well, if you want to do a transfer on day 3, you are asking yourself which of the embryos are the best embryos. You can't tell. But by day 5, you will see some would have formed blast, some would be at morula stage, which is day 4, and some will just stop, will just get arrested at the 3-cell stage or 2-cell stage. So you're able to tell, oh, this embryo is the best, these ones are not doing well, and so you won't transfer. So that is why we do day 5. It's more expensive to go through that process because there are more days of culturing, but it gives us a better outcome. So we do day 5. said occasionally day 3. Now so what you know is you know the day of your transfer once you've had your oocyte retrieval or insemination, fertilization done. So you can determine the day. It's 5 days after. So quick test. If you did your oocyte retrieval today or insemination, when will the transfer be? Saturday. Yes. When will the transfer be? Wednesday? No. Another? When will 5 days be? If you do your collection today, Saturday, when will the transfer be? Thursday. Correct. You start counting from the next day. Next day is day 1. So if you have your collection today or you have your insemination today, your transfer will be on Thursday. So that you already know. But the time of that transfer will not be told to you until the morning of the transfer.
Right.
That is the next question. I was expecting that question. The reason why we can't tell you the time is because it can be any time. Why? Because it depends on how the embryos are developing. So typically what will happen is that because of the culture we do the continuous culture, where once you have done your change of dish by day 2, day 3, you don't open the incubator again until the morning of the transfer. You check to see how your embryos are doing. So there's some, so the embryologist will probably check late at night on on Wednesday. Let's say, for example, you did your collection today, late at night on Wednesday, or very early in the morning on Thursday. So he checks the embryo and says, oh, these embryos are doing very well. We already have blast. Call these patients, we are doing transfer early in the morning, 10 a.m. So the nurse will start calling. Your transfer is another 2 hours. 2 hours? Sorry, we didn't give you enough notice because the embryos also didn't give us notice. We just checked it and they told us, transfer me now or I will hatch out. Yes, because once the embryo hatches out, outside your body, that reduces your chances of pregnancy. Because we want that hatching out to take place inside your womb. So as it's hatching the baby outside, let it hatch into your endometrium. Implantation will just start off immediately. So if it checks and it says, okay, it's still at the early blastocyst stage, we still have some hours. So you can say, okay, let's do it in the afternoon or let's do it in the evening. All right. Now, all of these times also depends on when the insemination was done. When the first today. If it was done early and the embryos are developing very well, then the transfer will be early. If it was done late, but the embryos are not that, the rate of development it differs. So that's what determines the time. So don't call the nurse and say, my transfer is on Thursday. Nobody has called me. They've not given me the time. Relax, be calming down. You get that call in the morning of the transfer, that this is when your transfer will be. And please pardon us if we give you a short notice. Because I know some people, they are executives. Maybe they have planned for one early morning meeting that day. That no, they won't come in, maybe it's most times in the afternoon. On this particular day, your embryos may decide they want to enter early. So once we call you that, madam, please, you need to come in by 9 a.m. This call is by 7:30. They'll say, what? I already have a meeting. Sorry. It's the embryo that determines the time. Okay? So you expect that call from them in the morning of the transfer. And okay, I did mention the protocols for collection, which also will apply for transfer. So the nurses will tell you, of course, there's a list. They will take you through that protocol on the day you're having your last trigal injection. All right, for collection, or the day you're having your last, the day before your transfer. And that means no perfume, no deodorant, no makeup, see all of this. We will see them the way they are on that day. You know, their natural beauty. Okay, so no makeup, because those things, they are not good for the embryos. Just take your bath, wash up, douche, and then you come. Okay, both on the day of collection and on the day of transfer. So you are required to be around at least 30 minutes before the for collection, it's done under anesthesia. During eating, because it's not done under anesthesia. Whether to eat or not eat, eat. Because some just say, doctor, I am hungry. Please, you have to eat. Choose not to eat, no problem. But eating does not. So make sure you eat before you come. And then once you come in, you be given water. All right, because it's done under ultrasound guidance. They transfer water in your bladder. Okay. So the transfer is done. Next slide. You see that? No, go to that. So what we do in our transfer is that into the theater, we will show you. You see your embryos, and then how many will be transferred. We will determine on the bed. You are lying down, you are seeing your embryos. I will say, okay. I don't understand why women will say, I want 4, I want 4 or 5 babies. I don't understand. Typically, we'll transfer 2 or 3 embryos. We transfer the best embryos. Transferring 2 or 3, we are praying, and that is what we ask you. That we transfer 3, but 2 we implant. Sometimes the women go and counteract, they go and pray more and counteract. If you have 3, well, those who are not going to be doing that, doctor will take care. Me, I will. Okay. But usually we transfer 2 or 3. All the 3 may implant, or fortunately none may implant. But we aim to transfer 2. But I'm sure I need you to be aware that there are some centers where they do single embryo transfer, but you need to qualify for that and determine whether you qualify to have a single or 2 embryos transfer. Now, most of our women, backed by the men at once, to compensate for the years of waiting. Compensate. So you'll say, doctor, please, you do know how many years I've been waiting? Please, I want to just have them once. 2 or 3 embryos we would transfer, and then we'll show you what the embryos are.
So we have an optimum.
Yes.
So that even he lost his life, he lost his transfer. But
So,
he had a case to say it was because the chances all of it was
but that is but
and
no. It's too much. We've had the reason why anything more than 3. And even when we're looking at the embryos and we're saying that most likely not all 3 will implant, of carrying multiple pregnancy. See, forget the fact that some will carry successfully. 3, 4, wow! For everyone others that did not succeed. Well, careful, and no woman should give her life in exchange for a baby. And so safety is key. And if you're carrying multiple and then you have to deliver prematurely, of intensive neonatal care is more than. So you say, oh, I want to use 1 stone to kill. The cost of neonatal, if everything goes well, you get to 34 weeks and above, fine, praise God, but not everybody. Beautiful. Because the difference between 1 and 2 is not much. The woman who is carrying the outcome, they do very well. So that's why I say, go. And someone will say 3, no problem. No problem. But some carry 3 successfully. We have a lot of them, truly, but all right, so you will see that on the screen when we do the transfer. You won't see the embryos. Fully at the scan machine, you will see when will just drop. Those are your babies. Okay? Show it to you. All right, it's done under ultrasound, and you just load the babies inside the catheter, bring it. We already have prepared you. Touch it, and the inner catheter will just come with the babies, go in and off. Now, this is the reason why we do your mock, the mock embryo transfer. Because if that is not, and some patient had stenosed cervix on the day of transfer, trust me, it will be a challenge. But because we couldn't transfer, because was challenging. The mock was even done. It was even done in theater. For her, she has a peculiar cyst we need to deal with. No, not really. Once we've done your mock and everything, on the day of transfer, everything should go well. There are some patients who will have their mock done to say that during the mock, when you're supposed to do your mock, they may try it. But sometimes we may want to do your mock and we discover that the service is closed. We try to do it. We may decide that we want to do it in the theater to open up your service and ensure that terms and conditions will apply. Yeah, so that's what, so measurements during the mock. So on the day of transfer, less than a minute, going, stop, check, push, babies are delivered. So the whole process takes less than a minute. All the preparations, cleaning and everything may take up about 10 to 15 minutes. It takes a very short time.
But you will set jumping up.
What is expected? The patient's instructions on the do's and don'ts. After transfer, drop around, you can travel. Some women are saying, me, after I've carried these nations, to be jumping, that will not even allow me, will just grant me. So you go, I'm president too. So now the question is this. There are patients whom we have had, after their transfer, they went home and they hung their legs on the bed. They didn't go anywhere. 2-3 days, they didn't take their baths. They slept on the bed. Everything was on the bed. If I thought they went to go and eat themselves, just to crawl, go to the toilet, and then they come back. And I said, for what? Please, I don't want stories that touch the hearts. No, but honestly, the evidence doesn't show that bed rest improves. So patients often ask, after the transfer, can I get back? I said, yes. What do you do really? Except those things that actually stresses you mentally, that makes you psychologically, you understand? Even if you're, anything that has to do with activity that doesn't stress you, nothing. The embryos will not fall off. Transfer, I know that where you do your transfer is upstairs in the theater. So when you're coming down the stairs, you see the way women are counting their stairs. They are walking like royalty. Oh my God. I said, what is it, doctor? The babies will not fall. They won't fall. Trust me, they won't fall. They are there. No, I was going to come to the men. The men, they have their role. What actually disturbs and what should be avoided is psychological trauma. So men, it's not that time you start quarreling with your wife. Anything she does is right. Yes. Oh, you want this? Do it. Don't say, is it because, please. That is actually the worried. Once she's not happy, once she's traumatized psychologically, her body starts producing cortisol. And that will now begin to antagonize the whole process. And then that's what can cause the challenge. It's not the fact that she's working or she goes to the market. Activity does not really affect. As long as the woman is happy and she's working, she's going through her routine activity, happy because the spouse is doing, and please, during this period, just forgive them. Because the women are going through hormones. And when a woman is going through hormones, sometimes she does things that are not rational. She's telling herself, but why am I doing this thing? She's doing it because of what? The hormones. As the husband, don't say, just say, oh, I understand. They said, okay, it's okay, it's okay. So, no, it's okay, it's okay, it's okay. Don't pick offense because you will jeopardize all the efforts. Wants to eat shawarma. Shawarma, no problem. Is it chicken suya? Okay. I get it for whatever she wants. If she just wants you to be rubbing her feet, just rub it. Whatever she wants to make her happy, do it. Okay? So you wanted us.
Most women used to propose post and love.
Yes, I agree. I agree with that because most women will say, oh no, I have to, because women would say, I want to take leave off from work for 2 weeks. I said, why? Say yes, after the process. So, okay, what do you do at work? Well, nothing, just to sit, have an office, sit down, work the computer, nothing. So you don't need to stay at home. It's even worse because trust me, from data, the most critical period, if I may put it, of this whole process is the 2 weeks after transfer. 2 weeks will become like, God, yes, before the test. hey, I hope this test will be positive. Or any little thing you feel to give it a meaning. That you feel once more, maybe the baby has. And what is that causing? It's causing a lot of anxiety. You will forget it, but if you're at home not doing anything, trust me, your mind, so many things. So we ask the women to please, but if your work is truly been praying for an opportunity to truly take a break, why not? After the transfer, we ask you not to, in terms of food, eat healthily, fruits, use of potash. But for all those who like eating okwobi, abacha, all those things, you just suspend that. And no sex. Men, how long? It depends. That extends for another 2 months. So by the time you are finally released from quarantine, the woman is already 5 to 6 months. And based on the way she's looking and she's feeling, by herself, she may just close it and just say, Oga, just wait until after delivery. And after delivery, you wait for another what? 6 weeks. And so you can do the calculation. All right. But usually after 5 months, you can resume intimacy. Okay. So after the transfer, next slide. 14 days after the transfer is when you do your pregnancy test. And for those who are based in Abuja, we will prefer you come into the hospital to do it. Why? So that we can immediately give you a counsel, whether positive or negative. But if you're not based in Abuja, you do the test and then you send us the result. And based on the outcome of the result, we will still arrange to give you the necessary counsel. Next slide. This is what we expect for all of you.
Amen.
This is what we expect, that we'll show you the 2 lines which shows that you are pregnant biochemically, but it's the 2 weeks after this test that really shows. And that is when we confirm clinical pregnancy, when we do your scan to determine how many you're carrying. You know, we prayed and say, okay, we transfer 3, and we now know how many, yes, got implanted and how the babies are doing. All right. Now, for those who unfortunately will not be pregnant, because this process is not 100%. Reproductive medicine is not 100% anywhere in the world. There are so many factors that makes it so. God did not design it to be so. So for those who will not be pregnant, we would counsel you immediately. For those who are not, both those who are based here in Abuja, who will say, we'll give you another 2 weeks appointment. Because a lot of what we'll be telling you then will not make any meaning because you are still very emotional, you're grieving. So we'll just tell you the result and just try and help you at that stage. But the next stage, to what to do, why it failed, and all of those things will be done 2 weeks after the result is declared. Because it gives us time also to look inwards, meet with the team, because we usually have reviews here. Okay, every week we have reviews, and part of what we do is to review all the negative tests and find out why did this woman not get pregnant. And we're looking at all the various
Hello, sir. We can't hear you again, sir. Hello, sir. We can't hear you again, sir.
And if we are changing the treatment option, we would have told you that, okay, this is what you did the last time, and this was what the outcome was, and this is what we are doing this time around. And once we've reached that agreement, and then if depending on the program you are, if you're on a program that does not require you to make any additional payment, we just go ahead and plan your program, and then we execute. But if you are on a program that requires you to make an additional payment, like through the foundation, then once you make that payment, you are starting your next program. All right. So those online, if you have any question, we'll also give you the opportunity once we are done with this in-house. So.
Okay.
Okay, ICSI is, okay, let me explain what ICSI is. The ICSI, intracerebral sperm injection, is a process to achieve fertilization. It has nothing to do with transfer. So if the man's semen parameters requires that ICSI is done rather than the conventional IVF. In conventional IVF, the sperm and the egg is put together and the sperm would swim to fertilize the egg. In ICSI, you're taking the sperm and injecting it into the egg. All you're trying to do with ICSI is to increase the rate of fertilization. But once there's fertilization, and then you now allow the fertilized egg to now develop. All right. Whether it's through IVF or ICSI, they go through the same process of development. And on the day of transfer, we check to see if we have what the embryos are. Okay. Now, let me say this. I think I failed to say that, and I think it's very important. It's not a good thing. It's not something that any patient will like, but I need to say it because sometimes it happens. You know, like I said before, that
Sir, we can't hear you, sir. Hello, sir. We cannot hear you.
to see if the embryos, can you hear me now? Yes.
Yes,
To
we
see
can hear you now.
embryos are viable. In a few number of patients, when the embryologist will check, they will realize that some embryos are not viable. If we don't have viable embryos, meaning that embryos that when we transfer have the potential for implantation, we will not transfer. Rather, what we will do, we will call you and we'll explain to you what we're having and the possible reason why it is like that. even for patients who are going through recipient programs. It does happen because it's an interaction between the egg and the sperm, and the quality of the embryo is that the quality may not be good. And even for the sperm, we may even get sperm that meets all the criteria for normative. Count is okay, motility is fine. We just needed to say that sometimes it does happen. Okay. Okay. Further questions? Any question online? If you have a question, you can probably just, I can see a hand raised up. You can unmute your mic and then ask your question and then mute your mic so that you can hear the response.
Okay, sir. Good afternoon, sir.
Good afternoon.
Yes, sir. Thank you, sir, for the wonderful presentation. Yeah, this is my question. The first IVF that we did before somewhere, they introduced cycloges for my wife. So in the process of using that cycloges, she complained about private part inching and then some pill, but they were unable to give us a solution to that. I don't know, maybe that cyclogel will be also used in this process also. Thank you, sir.
Is one of the hormonal medications that you would use. And that is usually given after your transfer. Okay? The first progesterone that you take is the injection, which is started on the day of insemination or a day after insemination. And once you have done your transfer, you are given that progesterone insert, cyclogest.
Sir, we can't hear you, sir. Hello, sir, we can't hear you.
Yeah. So I'll say all we have to have a lot of study change, and if that is the other options, but I'm not going to try and if that's the case, what will happen is it stop what is that for then the other additional ones are not added or but it must be on the church. We are not sure we are confident.
Thank you, sir, for this wonderful interaction, sir. Please, sir, we are not hearing.
Yeah, not hearing you.
Can you hear me?
No, sir.
Gbọ́ answer tó ṣe ẹ̀sọ́ gbọ́. But ó ní pé wọ́n máa lò ó láfíà tó bá ti transfer kìíní kan yẹn.
What? It's not there. Can you hear me now?
Hello, sir.
Next question.
Yes, sir. Please,
Yeah.
sir, concerning the scan.
Yes. Any question?
Yes, sir. Concerning the scan that will be taken every week. Those that are not in Abuja, can we do it and send it to you, sir? Sir?
Yes. Okay. Thanks for that. Yes. We can. So for those who are not, we will have a scan for
Please, sir, we are not hearing you.
Hello, sir. We can barely hear you here. Hello? Hello? Hello?